Hello, hello. Welcome to the Auditory Learner. This is going to be the final study guide for the remainder of Periodontology 2. In order to prepare for the final, we're going to be talking about dental implants, placement, consideration, and management, different types of dental implants and the steps that go into that. We're going to talk about guided tissue regeneration. And then we're going to be ending it with the resective and reconstructive periodontal surgeries. Okay, so let's get straight into it. We're going to start with the implants. So for implants, they are a replacement for missing teeth. They are considered a biomedical device of inert material or metallic alloy, and it's placed within the bone. One thing that Professor told us is that we need to go with what the American Academy of Periodontologists say, even over the manufacturer. So AAP supersedes the manufacturer of implants, even over manufacturer, correct. So what do we need to consider when people get implants? We need to consider their medical status, their health status, their oral health status, their motivational status. And these things involve, like, if they're alcoholics, if they're smokers, if they have diabetes, systemic condition, if they've had radiation. Those are all risk factors. There is no difference between someone who smokes moderately to someone who smokes heavy. So moderately is 11 to 19 cigarettes per day. Heavy is 25 or more per day. There's no difference between those in risk factor. For alcoholism, can cause avascular necrosis, and it also disrupts osseointegration. Also, stress. These are all inflammatory markers, and active periodontal diseases increase the failure status. So other things we need to consider is the occlusion of a person, the quality of their tissues, and the bone quality. This is why we need to do a CBCT scan, a 3D imaging. We need to know the position of the implant in the alveolar ridge for the stability and aesthetic reasons. So like the density of the bone, the width, the height, those are all things that people who place implants need to consider. The type of diagnosing techniques for implant are we can use panoramics, lateral occlusal views, and periapicals. Sometimes they can use casts, but there are also surgical templates, which are surgical stents for implant placements. Periodontal evaluation, we need to understand the arch relationship between both arches, if there might be a need for ridge augmentation sometimes. Very important, there's 1, 2, 3, 4 types of implants. And these are the frame type, which is also called subperiosteal. Then there's the through type, which is the transmandibular. To me, is one of the most craziest types. Hopefully no one's ever getting those. Then there's also endosseous or endosteal implants, which are the most common. And then there's the zygomatic implant. So subperiosteal, frame, transmandibular, through, endosseous, endosteal, 1, and then zygomatic, which is through the zygoma. So the subperiosteal implants, which are the frame type, those are rarely used at the present because there's also a high incidence of infectious complications. Also, the jawbone will resorb, and then it requires 2 surgical procedures, and it becomes surrounded by scar tissue. So these also, on an x-ray, they look very, very intense. Again, rarely used. Anything else that we need to mention about this? Designed to retain an overdenture. All right. So pretty much for like a 4-on-4, how they would use it, but before they would place it with the frame. So now let's talk about the transmandibular implant. This is a through implant. These are to retain a denture on an edentulous lower jaw. Transmandibular, so that can only be on the mandible. Can't do a transmandibular or a through on the maxillary. It's rarely used at present. Um, it's rarely used at present. And it's also called a staple bone by Small, and um, which is made by a company named Small, and then another company makes these transmandibulars called Bosker. Uh, Splint adapted to lower border of mandible. Survival rate is 90% after 15 years. But the Bosker one is 70% survival rate after 5 years. Damn, survival. It sounds like they might die. But it's used to retain a denture on a dentureless lower jaw. Again, rarely used. This one is just seems like too much, man. Like a bad idea. Looking at the X-ray, definitely looks like there could be complications. And you got a horrible picture of a guy who's like leaking from his chin because of it. And again, not the type of stuff I'd want. Then there's endosseous implants. There's the or endosteal implant. It's the most common type. There's different sizes, shapes, and widths, and um, it's either screw shaped or threaded, cylindrical. Usually, it's can do one surgical procedure or two surgical procedures. Okay. So we know how they place it. I've seen it many times. A flap exposed, alveolar ridge, implant guided, predetermined depth. Yes, not up to us how that's done. But once that's done, you place a cover screw on it, which is the healing, which is the cover screw that maintains the hole. This is where we get into the two-stage, one-stage, and immediate stage. So there's three different types of surgical approaches for the two-piece implant system, which is the implant itself and then the tooth on top. So the two-stage implant is one where the healing abutment is submerged. Okay. Um, that is a two-stage because they place the implant, they put this little screw on top of it, then they cover the tissues and suture it over. That's the most common one. That's going to need an uncovery surgery to place a healing abutment and perhaps also to take an impression. But that's a two-stage. One stage is where they place the implant, um, and then they also place the healing abutment on it, and they uh, the sutures are around the healing abutment, meaning that the healing abutment is exposed, and so they just stay like that until it's time to take the impression after a couple of months, 4 to 6 months. Then there's the immediate restoration where they place the implant and then they place the tooth right on top. That's going to be immediate restoration, probably not recommended. So what is osseointegration? It's a direct structural connection between implant surface and bone. There is no soft tissue integration, no connective tissue, and no periodontal ligaments happen during osseointegration. It's strictly between the metal, the titanium, and the bone. And if it's all good, there should not be any mobility. There should be no give, just like a cement post. It's made of titanium coated with hydroxyapatite. Biointegration means independent of mechanical integration, resembles bone tissues. That's why we take an X-ray. Sometimes these things are acid etched and grit blasted, and they're sprayed with plasma. So there's up to 90% success rate. Rough surfaces is a greater success. Usually the mandibular implants have a greater success rate than the maxillary implant because the mandibular bone is denser. It's more successful than management of molar furcations. So an implant is more successful than molar furcations. Root section therapy might be needed. Successful in those prone to periodontal disease. This does not mean active disease. So maybe a reduced periodontium, it will be good. So yeah, there's a restorative phase. Then there's the cover screw is removed, similar to crown, but crown is placed. Implants should not be mobile at all. Okay, now probing is very controversial due to the type of bone to implant attachment. We need to assess the tissues for presence of inflammation. If there's inflammation, maybe we probe. But the radiographic evaluation will probably be the best. And then the last type of implant is a zygomatic implant for used for both two-stage and immediate loading protocols, usually placed using an immediate loading protocol, used with severely resorbed maxilla. So again, zygomatic implants are you can only get them on the maxillary. You can't get them on the mandibular. Uh, it is used as an alternative to a sinus augmentation or a failed sinus augmentation or rehabilitation after tumors or resection of trauma, failure of conventional implants, or failure of previous bone grafts. So that would be like the last thing for the maxillary. Um, and they're very long. They go into the zygomatic bone, and they look a little unappealing, to be honest. Long-term studies with the classical two-stage immediate loading is a high success rate with only minimal complications. A cumulative survival rate is 96% after 12 years. Most common complication for zygomatic implants is sinusitis. Other ones are infraorbital paresthesia, oral sinusal fistula, and perforation of the orbit. That sounds horrendous. So there is peri-implant mucositis, which involves the gingival tissues only. Then there is peri-implantitis, which is inflammation that is visible with the presence of pockets. With exudate on palpation, there's mobility, and it leads to ultimate failure. So peri-implantitis is not as bad. No, peri-implantitis is worse than peri-implant mucositis. Again, peri-implant mucositis is gingival tissues only. Professor stated this very weirdly in her last quiz, and I put none of the above. I hope that was right. We will find out. Anyways, so what can cause complications to implants is occlusal trauma, presence of inflammation, pain, radiographic pathologies, loose or fractured components, and also medical history complications. Most common reason for failure is active perio disease, bruxism, and systemic factors or behavioral factors. Then we need to instrumentate these things with specific types of stuff that do the least damage to implants. Certain types of metals that are used, such as graphite, gold, plastic, medical grade titanium, but all instruments have been found to inflict at least a slight damage or scratches. Plastic, graphite, and gold are softer than the implant material. Plastic is not as good at removing debris. It does the least do the least damage to implant surfaces, but there is a risk of plastic residue on the implant. The medical grade titanium is still controversial, but is biocompatible, thinner than plastic. It can cause damage and scratches, but it's less than other metal scalars. Stainless steel metal scalars found to cause more damage than resin or graphite. Ultrasonic tip should not be used unless there is a plastic tip cover. It's because research shows that there's plastic shards and threading is possible. The scratches on the implant may allow bacteria or debris to settle and cause inflammation response. Instruments can leave their own debris behind, such as plastic, which can cause inflammation, and particles from the implant's surface may be found in tissue. All right, and that was it for that. Let's get into the GTR. GTR, the ultimate goal of regenerative periodontal surgery is not only to eliminate pocket death, but it's to regenerate new attachment apparatus and reconstruct the periodontal unit within the previously existing normal physiological limits. Bone grafts and membranes are in step in this direction. There are 4 modalities for pocket elimination and attachment apparatus. These 4 are repair, which is the long junctional epithelium via SRPs. There's resection, which is pocket elimination. There's regeneration, which is in bold, which is new attachment. And then there's extraction, which is tooth removal. Those are the 4 modalities of pocket elimination: repair, resection, regeneration, extraction. Repair, resection, regeneration, extraction. We're going to be talking about guided tissue regeneration right now. There's objective to elimination and attachment apparatus. To pocket elimination attachment, we need to remove the local factors, eliminate reduction of pockets, restore the alveolar bone, and these things can be achieved by insertion of materials in bony defects such as bone grafts, with or without membranes, and placing barriers, membranes over defects. So let's talk about guided tissue regeneration. All right, so this is epithelial cells. It's like a mechanical barrier that is placed between tissues and the osseous defect. Epithelial downgrowth will be prevented by cell contact inhibition, which will allow the periodontal ligament cells to migrate in the coronal direction and therefore promote true periodontal regeneration. So guided tissue regeneration inhibits epithelial cells. Okay, so the first cell to repopulate the root surface will determine the nature of attachment. Healing takes place by epithelial attachment. But again, if a mechanical barrier is placed between tissue and osseous defect, epithelial downgrowth will be prevented by cell inhibition. So guided tissue regeneration, let's talk about non-graft materials. Guided tissue regeneration is part of non-graft associated modality of periodontal regeneration. It's a surgical procedure. It's designed to manipulate those cells that can repopulate the wound healing site, ensure the inclusion of cells which will lead to regeneration. There are 4 possible sources of cells: the epithelial cell, the gingival connective tissue cells, the periodontal ligament cells, and then lastly, the bone cells. So again, guided tissue regeneration is by using bone graft and then placing like a collagen or some sort of membrane to help the tissue get up to where it needs to be. There's resorbable and non-resorbable types. And we still have to wait 4 to 6 weeks after removal and healing. It sometimes will require an elevation or a flap. So the mechanical barriers should stay in place for at least 4 to 6 weeks. Okay, so if like, for example, an implant is losing bone, you can place bone and then place some membrane over that to help regenerate implant sites. Membrane is placed at the same time as the dental implant to promote bone generation of a deficient bony ridge. So sometimes you can place an implant somewhere, even if there's not enough bone, but you have to place bone at the placement time of the implant. 6 to 9 months later, the bone has healed around the implant and the membrane is removed when the implant is uncovered for the placement of the abutment. So 6 to 9 months, yeah, that's a while. Again, we need to know what supracrestal tissue attachment is, or also biological width. The biological width is the junctional epithelium and the connective tissue, which comes to about 2.4 millimeters. Okay, so it is above the alveolar bone, okay, and right before the sulcular epithelium. So it's the junctional epithelium and the connective tissue, which equals this biological width or the supracrestal attachment. Okay, the junctional epithelium is 0.97 millimeters, and the connective tissue attachment is about 1.7, which equals to 2.4 millimeters. Okay. All right, cool. And then would be great to know this diagram of tissues of the periodontium. We have number 1, the gingival epithelium, which is like the very high part of the almost free gingival margin. Then the gingival epithelium, okay. Number 2 is the gingival connective tissue, which is right below the gingival epithelium. That's most likely going to be like the attached gingiva. And number 3 is the bone, and number 4 is the periodontal ligament, all the way at the bottom. Okay, very good. And the last one here is periosurgery. Let's talk about periosurgery. We need to know the difference between gingivectomy and gingivoplasty. Gingivectomy is removal of gingiva. Gingivoplasty is the reshaping of gingiva. Just like a osteoectomy would be removal of bone, and an osteoplasty would be the reshaping of bone. Okay, so these things may or may not be included with guided tissue regeneration. It might be mucogingival surgeries and graft. Okay. So we're trying to create a better bony architecture. Okay. It is thought that a pocket reduction cannot be obtained, but also maintained. Okay. So we need to understand the difference between positive architecture and negative architecture. Positive architecture is obviously good, negative architecture is obviously bad. The difference is here where the interdental bone goes coronally, which would be positive architecture, and the interdental bone goes apically, that's negative architecture. Positive architecture is osseous crest, follows the shape of the cementum enamel junction, and the interdental bone is more coronal than the radicular bone, which for radicular, we mean buccal lingual surfaces. So when you look at an x-ray, the radicular bone will basically be the bone that goes through the tooth, and the interdental bone is the bone between the teeth. So that's the areas we're looking at for positive or negative architecture. Negative architecture is osseous crest does not follow the shape of the cementum enamel junction. Interdental bone is more apical than the radicular bone. So if you look at that x-ray, if you see that the interdental bone scoops under and it is more apical than radicular bone, which is the one in between, then that's not good. That means that's negative architecture. Okay, put that picture in your head for the positive. You want to see a little crest in the interdental bone that goes higher than the radicular bone. That's positive. And if you see a flat all the way across, same, that's just flat. But if you see it a dip, a spooning between the interdental bone and the radicular bone, that's negative. Okay, so osteoplasty is the osseous resective surgery, osteoplasty and osteoectomy. The main goal is for periodontal pocket is eliminated. It's for bone reshaping. In this operation, the bone that is reshaped is not part of the attachment apparatus. No bony support of the tooth or teeth is lost. Okay, that was for osteoplasty. Osteoectomy, also referred as ostectomy, to remove the periodontal pocket, it was eliminated. Bone is removed and reshaped to achieve physiological contour of the bone and gingiva overlying. In this operation, bone that is removed is part of the attachment apparatus for ostectomy. Ostectomy requires the loss of some bony support of the tooth. The amount involved will be important to the criterion used. Okay. Indication. The most common indication is shallow two-wall osseous craters. So only two walls remaining. Osseous craters are connective tissues in the crest. The site of the initial periodontal lesion is usually the interproximal area, with the two-wall osseous crater as the most common type of osseous defect. So contraindications to this is deep osseous craters, three-wall osseous defects, moderate to deep circumferential. Bony defects situated on the buccal aspect of terminal mandibular molars. Terminal mandibular molars is just another word for the third molars. Osseous surgery should not be done in areas that have pocket depths of less than 5 millimeters. So it needs to be 5 millimeters or higher for osseous surgery. Again, so there's three-wall bony defects, which just basically looks like a hole in the bone right next to a tooth, 1, 2, 3. Two-wall bony defects is a little bit worse. I can see why, because this time it's not like a room. This time there's like a door leading outside of the bone, basically. It's no longer just a hole. It's like, boom, it's one wall is removed, and now you have to create a wall. And then there's the one wall bony defect, which is basically It's like a through and through gash. Um, but usually two wall bony defects are seems to be the reason for these surgeries. All right. So ostectomy wouldn't move forward for either. There's definitive osseous reshaping and then there's compromised osseous reshaping. Definitive osseous reshaping implies that further osseous reshaping would not improve over the result. Compromised osseous reshaping indicates a bone pattern that cannot be improved. So you wouldn't move forward with both. I think this is where I'm going to end it because it's really not that exciting. We're not periodontists. It's good to know this stuff. But again, the ideal osseous defect for a regenerative procedure is a three wall, as seen on the distal aspect. A narrow two wall defects are still good indication for reconstructive surgery, not ideal as three walls. So there's graft associated, and then there's non-graft associated. The different types of grafts, there's autogenous grafts, which means it's coming from the same person, either from their iliac bone or from their tuberosity or tori. There's allograft, there's xenograft, there's alloplastic grafts, ceramic grafts, polymer grafts. Again, an infrabony pocket is a vertical resorptive defect in the alveolar bone. LJE stands for long junctional epithelium. Reconstructive surgery, osteosurgery is the different periodontal surgical procedures directed by restoring bone, ligament, and cementum into original levels. Resection means periodontal pocket elimination surgery, gingivectomy, or apical displacement of gingival tissues. Regeneration means new attachment of same fibers. Gingivalectomy means surgical removal of a pocket wall. A hemiseptal defect is one or two wall osseous defects often found around mesially tipped teeth. And then an osseous crater is an interproximal two wall defect. All right. So we're going to end it there. All right. Cheers to passing Perio 2 final.